So to get into a couple specific terms, just so everyone's on the same page, if you are new to value-based care, these are, in my view, pretty much the most important terms, so you can get caught up rather quickly. Population health, let's just give an example. If 100 primary care physicians treat 10,000 patients, keep the math simple for my benefit, and let's say the total cost of care for those patients annually is $100 million. Well, the idea of population health is let's manage all of those patients to try to reduce that $100 million charge. And how do we do that? Well, we look at the population as a whole, and then we start to narrow down who in this population of 10,000 patients have chronic conditions that need to be better managed so that we can keep them out of the emergency room. So they're getting their primary care, not emergent care. Frequent ER use is one of the biggest costs in medicine. Why do you need to go to a hospital for $12,000 a day when you could have just taken some preventative steps to avoid that in the first place? Palliative care is an issue we're close to for a variety of reasons. On our advisory board is Paul Armstrong. He was the attorney who argued the original right to die case on behalf of Karen Ann Quinlan, and it gained a lot more traction recently because the cost of end-of-life care is extraordinary. And this is really about patient choice and patients' rights. It's not about withholding care. Social determinants of health is the next term that we're going to get into. It just basically means, so let's say a patient has a total hip replacement and goes to the best doctor in the world, and the surgery could not possibly have gone better. This was the best surgeon's best surgery. But this patient lives in the second floor of a walk-up, and when she gets home, she's going to go up and down her stairs a couple times, and it's going to cause a complication. Well, if we only knew about this in advance, we could have taken precautions. We could have put her in a hotel or a skilled nursing facility for a couple of days. There's a lot that we could have done to avoid that very expensive, several tens of thousands of dollars potential complication. Another example of a social determinant of health is, all right, I live with several family members who can take me to and from my follow-up appointments, for my rehab, for all my care, or I don't. If I don't, maybe we need to make sure home health is there to provide better care and is there more frequently, as opposed to this patient, when they need to go to their next doctor's appointment, picks up the phone, calls the ambulance, goes to the hospital, and that becomes the very expensive follow-up care. Bundled payments, we talked about this, just $30,000 for a case. Bundled payment models are mainly fee-for-service models where there's a reconciliation at the end, but we do have that leader coordinating care. It's important to understand a prospective bundle is where we are going. There are some groups who are already in this space where you actually just get that $30,000 up front, or obviously whatever that negotiated amount is, and you use that to cover all of the cost of care, and if there's more, then you pay out of pocket. But prospective versus just fee-for-service is important to know the distinction. Convener, I just wanted to mention this because it's a very specific term of art. A convener holds the contract in a specific program called BPCIA. We're going to touch on that program. It's a CMS program. Convener files the application, takes all of the risk. This risk can be shared, but the government's not going to care who the shared risk takers are. They're going to just look to the convener. Conveners may represent one group, or they may represent hundreds of groups. But that term, in case you hear it, is pretty specific to BPCI. Attributed lives, simple enough. In the example we gave where there's 100 primary care physicians treating 10,000 patients, that is 10,000 attributed lives. That's what they're known basically in the risk and / insurance space. The benchmark in that example would be the $100 million. We know that the average cost of care is $100 million. So how do we improve upon that benchmark? And one way is we set a target price. So we say, okay, if the benchmark is $100 million, let's set the target price at $97 million, under which money can be made by the participants, because we want to reduce the cost of care. The first, few dollars is what we're trying to eliminate from the system anyway. If you can get below that, then you can make money. So another important term is the safe zone. Some programs say right off the bat, you have to save 3% or you owe a penalty. Well, there's something called the safe zone in other programs that says, all right, if you're above the target price, but you're under the benchmark, there's no penalty. You don't owe anything back, but you're not going to start making money until you get below the target price. This final concept, per member per month, critically important. We think it's essential in some programs to give extra dollars as the payer to the providers to build a value-based care infrastructure. There's a lot that goes into it.